Dear Marrowlings, welcome to this video where we are going to talk about Psychiatry May INI-CET 2023 questions. Now, the topics covered were hallucinations, delusions, substance use disorder, dissociative disorder, eating disorder. Now, if you look at this list, very commonly you get these questions on hallucinations, delusions, psychopathology easily. Substance use, especially alcohol, is something which is quite commonly asked. Now, eating disorder is also a standard repeated question which comes in. In this video, we'll talk about only 5 specific questions which are related to psychiatry. There are a lot of overlapping questions and integrated questions which will be taken up by other faculties of Marrow. The first question here is the tactile hallucinations seen in a patient with chronic cocaine intoxication is what? Is it oneroid state? Is it dipsomania? Is it carfologia? Or is it formication? What do you think is the answer? Any student who has gone through the videos or has read QBanks will easily answer this question, because when you're talking about tactile hallucinations and cocaine intoxication or chronic cocaine use, you know we're talking about cocaine bugs, which is also called as cocaine psychosis, right? What is the other name for it? Formication or Magnan syndrome. What is this Magnan syndrome or cocaine bugs or psychosis or formication? Here, typically you have delusions of persecution, where you believe somebody is planning to harm you or kill you, somebody is trying to destroy you. Such kind of delusions of persecution happen. Along with it, you generally have tactile hallucination. What is the type of tactile hallucinations you have here? You have the tactile hallucinations of insects crawling underneath the skin. You feel as if some insects are crawling underneath the skin. That's why the name cocaine bugs is used for this condition. And this is what is also called as formication. You might have read this even in your forensic medicine, right? So that's the answer for this question, formication. Now, looking at the other choices, there are a few interesting points to know because they also do get repeated sometimes. Let's take up one of the important terms, oneroid state. Now, when I'm talking about oneroid state, right, it is just not oneroid state. There are 2 other words we should know. One is twilight state. The third one is stupor. Now, these 3 words commonly get confused by the students quite a lot. Now, I'll keep it very simple for you to understand what it means. The word oneroid state is linked with something like dream-like state. Understood? Something like a dreamlike state. In a patient with oneroid state would be quite confused. He's not sure whether he's dreaming, whether it is reality. He's kind of in a confused dreamlike state. That's very common in people with oneroid state. It can happen because of substance use. It can happen because of organic conditions of the brain. What about twilight state? When you're talking about twilight state, the exact word which is looked at is, you look at a discontinuity in the consciousness. The person is conscious completely and oriented. There is a discontinuity in that consciousness. That is very characteristic of twilight state. Along with it, you also generally see outbursts. When I talk about outbursts, what outbursts are we talking about? Emotional outbursts, behavioral outbursts, sudden outburst of anger or emotions could be typically seen in these patients. So twilight state is a state whereas discontinuity of the orientation and consciousness. Along with it, they'll also have outbursts during these times. That is what is called as twilight state, which can happen. This is known to happen in patients who are delirious, patients who are into substance use, sometimes organic conditions, head injuries can also bring patients in twilight kind of state. What about stupor? Stupor is also called as akinetic mutism, right? What is this akinetic mutism? If you look at this word clearly, you understand what it actually means. Akinetic mutism basically is a state where you are not moving around and you're mute. Akinetic, you're not moving around and you're mute. But the most important point is the patients mostly are quite alert during this phase. They're quite alert. They know what's happening in the surroundings, but they don't respond, or they are not able to respond, or minimally respond is what you need to understand. Now, this is very characteristic of stupor. So stupor patients are alert patients. They know what's happening around them, but they don't respond and they don't move around. So akinetic mutism in alert state is typically seen in stupor patients. Understood? So this is typically again seen in some specific brainstem injuries, and deeper brain tissue injuries are one of the reasons why stupor can happen. Now, in exams, when they ask you the next time these questions, please remember oneroid state is a dreamlike state. Twilight state is a state where there is discontinuity of consciousness in the orientation, and there are outbursts of emotions and behaviors which can be seen, whereas you see in stupor what you call as akinetic mutism, where the patient is alert but is non-responsive or minimally responsive to the stimulations around them. That's important for you to know. The next word is dipsomania. And I'm sure you know what is dipsomania, right? It's an irresistible urge. For what? Irresistible urge or a compulsive urge for drinking. Somebody who is into bouts of binge drinking is what is called as dipsomania. Irresistible urge or compulsive urge to keep drinking. Other impulsive conditions which are quite commonly repeated are kleptomania, where there is a compulsive stealing habit, which comes in pyromania, where they do fire setting habit. What are the two words? Satyriasis and nymphomania. And satyriasis and nymphomania are what? Satyriasis is nothing but here you typically see an increased desire. And nymphomania also you see increased desire for sexual activities in males is called as satyriasis. Increased desire for sexual activity in females is called as nymphomania. Understood? So going ahead to the other terms, what is this Carfologia, or it is also called as flocculation? What is this Carfologia or flocculation? These are lesser known terms which are commonly seen in patients with delirium. What is this? If you see delirium patients in your clinic, right, you see a lot of these patients constantly keep picking their clothes. They keep picking the bed sheet or the clothes around them. Now, what are they doing? This cloth picking behavior is what is called as Carfologia or flocculation. It is what is called as Carfologia or flocculation, and that is the term given here. Now, going to the next question. What is the next question? Which of the following is used to define dependence? So they have given different features and asked you. Now, how do you define dependence? It's a very easy question. If you have looked into the videos, you know I have clearly told you there are 6 important features which you look for dependence. What are the 6 important features you look for? Craving, control being lost, tolerance, withdrawal, salience, and harmful use. Salience and harmful use. If you know all of these important features, then you would have easily answered the question. What's the answer for this question? All the 4 which are given here, A, B, C, D, are important choices to define dependence. Getting it? So dependence is related to 6 important features. Patients can have craving, control being lost, tolerance, withdrawal, salience, and harmful use. What do you mean by salience? Salience is giving importance to that particular addictive behavior more than anything else. And harmful use basically means you are using the substance despite the substance or the behavior causing a lot of harm to you. Physical harm, mental harm, social harm, legal harm, financial harm. Despite that, you continue to use it. That's what is called as harmful use. If you look at the choices given here, choice A says strong desire to use the drug, which is definitely what we call as craving. Priority to use the drug other than any activity is what is called as salience. Increased tolerance is part of dependence, and persistent use of drug despite knowing harmful effects is what is called as harmful use. So all of these are seen in defining dependence, and the choice is A, B, C, and D. Let's move to the next question. An interesting question. A boy is experiencing low mood, decreased energy, and decreased interest in the surroundings. On that, he is also not taking food for the past 1 week or so. This thought sample says the guy's mental status examination says a thought sample of, I lost my head, I am dead, how can I eat? So what is this delusion is what they've asked. What is the question? The question is about what is this delusion? Now, answer is, for you to know what delusion is this, you need to see the content of the thought. He's saying, I lost my head, I am dead, how can I eat? Now, is basically talking about completely gone case. He's saying, I'm completely gone. Nothing is there. My intestines are rotten. My blood is not there in my body. My brain is not working. My heart is not working. I'm dead. I'm a dead soul moving around. Such kind of things are typically told where? Very simple, right? You know, it is seen in nihilistic delusions. Nihilistic delusions. They've asked, where do you see this delusion? The answer is nihilistic delusion. Now, this being a recall question, right? Students recall different things. Now, some of the students said there was Cotard syndrome in one of the choices, and is it Cotard syndrome? Now, Cotard syndrome is basically a condition where you do see nihilistic delusions and severe depression. When you define Cotard syndrome, Cotard syndrome is a syndrome or a situation where you see nihilistic delusions in severe depression patients. So in this patient also, it does look like the patient has depressive symptoms. It is just 1 week of symptoms, but it does look like the patient has depression symptoms and nihilistic delusions. Maybe it will turn out to become Cotard syndrome. But the point here is, since they've asked which delusion is this, you can put this as nihilistic delusion, and the exact words in the exam would matter, but with the kind of given sentences by most of the students, we should go ahead with nihilistic delusion as the type of delusion we are talking about here. Now, why do you think the patient is depressed here? Because you see 3 core features. What are the 3 core features of depression? EMI, energy being low, mood being low, I, interest being low, or anhedonia. So those 3 are given. So it's a very classical possible depression symptom which we are seeing here. Understood? Now, what are you talking about bizarre delusions? Bizarre delusions are typically seen in which patients? Schizophrenia patients. In schizophrenia patients, bizarre delusions are typically seen. Now, here is where you need to understand bizarre delusions are very unusual, really abnormal, difficult to explain kind of delusions. It's very, very characteristic of schizophrenia. It is very, very characteristic of schizophrenia. Getting it? And these days, they don't use it as the primary criteria for schizophrenia, but clinically, we know whenever a patient comes with a very abnormal, bizarre kind of delusion, it's mostly schizophrenia in this patient. What about hypochondriacal delusion? Hypochondriacal delusion is a false fixed belief of having a illness which is possibly not there in reality, but this person is believing that they have it. They don't have HIV, but they think they are 100% infested with HIV. You do test and show them, see, all the tests are negative, you don't have HIV, but they are 100% sure that they have HIV. Now, if they have a doubt that they have HIV, if they're not very sure about having HIV, it is called as hypochondriacal ideas. When do you call it as hypochondriacal delusion? You call it as a delusion when it is a false fixed belief. They should be 100% sure that this is what is happening. Despite giving evidence contrary to it, they should be 100% sure. Then you call it as hypochondriacal delusion, which can happen. This again happens in depression patients, schizophrenia patients, or delusional disorder patients. Understood? Going to the next interesting question, a very simple question, quite repeated question a lot of times. Where do you see la belle indifference? La belle indifference is seen where? Now, is it seen in schizophrenia, conversion disorder, depression, or mania? Now, answer is conversion disorder. Now, conversion disorder is nothing but a type of dissociative disorder. So, in some exams, they can give you dissociative disorder as a choice rather than conversion disorder. Either ways, the answer remains conversion disorder or dissociative disorder is where you see la belle indifference. Now, when you're talking about conversion disorder, please remember there are in DSM-5 different term used, in ICD-11 different term used. In DSM-5, what is the term used? Functional neurological symptom disorder. The new name for conversion disorder is functional neurological symptom disorder. What is the very, very old name for conversion disorder? Hysteria. Some of the doctors in your hospitals who are quite kind of old and outdated, right? They still write hysteria as a diagnosis. Now, hysteria is a very old term which is used for conversion disorder. The newest term, if you want to use, is called as functional neurological symptom disorder as per DSM-5. Now, what is the ICD-11 name? The ICD-11 name is dissociative neurological symptom disorder. Dissociative neurological symptom disorder. Now, there is one difference here you should also remember. Conversion disorder is considered as a type of dissociative disorder in ICD, whereas in DSM, conversion disorder is considered as a type of somatic symptom disorder. That's also a difference point you could know. They don't ask you in exam, but if they ask, you could answer it very easily. What is la belle indifference? Patients with dissociative disorder or conversion disorder present with huge symptoms, right? They suddenly come and say, I'm not able to move my hand. Suddenly come and say, I'm not able to have vision. I'm not able to walk. Such kind of different, very bizarre neurological huge symptoms they come with. Even though they come with such big symptoms, their emotions associated are very less. They don't show that much of emotional connect. See, for example, if I lose my limb functioning or eye functioning, or suddenly I'm not able to walk, I'm going to be very worried, tensed, anxious, irritable, upset, right? That emotions are not much seen in these patients. That is what is very, very typical of this condition where we are talking about conversion disorder. That's why it's called as la belle indifference. What is la belle indifference? The mood is indifferent to the presentation. La belle indifference is mood is indifferent to the presentation. There is one more word which you should know, which is also repeated in MCQ exams. What is that called as? Anaesthesia abasia. Now, anaesthesia abasia is also seen in conversion disorder. What is this anaesthesia abasia? It's a bizarre, abnormal kind of gait presentation. It's a bizarre, abnormal kind of gait presentation where patients are finding it very difficult to walk. They're very wobbly, or they walk in one leg and come, or hop and come, or they walk sideways. They have very bizarre gait presentations, and they come in the background of social stressors and psychological stressors. Now, that is how conversion disorder patients can present. Don't forget about these two words. La belle indifference, anaesthesia abasia can be seen in conversion disorder, which is nothing but a type of dissociative disorder. So moving on to the last question of this video, here we are talking about Stonk protocol is used in assessing what? Mental health disorders, sexual issues, eating problems, behavioral problems. Where do you use Stonk protocol? This was a very old question which was discussed, but these days people stopped asking. So again, it has resurfaced now. What is this Stonk protocol? Stonk protocol is a questionnaire which is used to assess eating disorder. It is a screening tool basically. Stonk protocol is a screening tool or a screening questionnaire to assess eating disorder. What does this screening tool consist of? It consists of 5 questions. What are the 5 questions dealing with? SCOFF. What does SCOFF stand for? S stands for sick, C stands for control, O stands for one stone, F stands for fat, and F stands for food. So these are the 5 important questions you should ask for. What is this one stone, by the way? One stone basically is a very colloquial UK use of word. One stone means 14 pounds of weight, or about 6.35 kgs. So if you want to ask somebody, have you lost too much weight? They used to ask, okay, have you lost about 1 stone of weight, which is about 14 pounds of weight. If you lost too much of weight, they'll say, oh, it looks like you've lost 1 stone of weight. Was a UK colloquial way of talking. So that is also one of the questions here. So what does the 5 questions mean here? The 5 questions are: 1 is sickness, then control, 1 stone, fat, and food. The kind of questions you are asking here the patient is, the first question is like this. You ask the patient, do you eat so much that you end up feeling sick after eating? They say yes. That is the first question. Second question is control. What are you asking about control? Do you lose control about the amount of food you want to end up eating? So control. 1 stone. In the recent times, have you lost 1 stone of weight, about 14 pounds or 6.35 kgs, right? 1 stone of weight. What about fatness? Do you feel you're more fat than what others perceive? Even though others think you're thin, do you think you're very fat? Now, this is trying to assess for the body image distortions which can happen in eating disorders, right? Then the last screening question is, do you think food predominates your lifestyle and decisions today? Are you constantly worried about food intake, how much, what, why, all those things? If that is predominating, then maybe there is an eating disorder. So these are 5 questions you should ask for as a part of Stonk questionnaire. 1, to assess whether they are feeling very sick after eating too much, whether they have lost control, 1 stone of weight, then fatness, and then food predominating their lifestyle. Out of these 5 questions, the moment they score 2 or more questions which are positive, if they say yes to 2 or more questions, then you should think there is a potential eating disorder happening in this patient, and you need to do more detailed workup to find the type of eating disorder. Since we are talking about some of the outdated older questions, I thought it is also important to know a very important question which can still be practiced and not as these days in exams, but good for you to know. For sexual health or sexual dysfunction, right, there is this Explicit model. There is this Explicit model which can be asked. Now, Explicit model of intervention or therapy is very useful. What is this Explicit model? It's an acronym standing for PLISSIT. PLISSIT. That is what is called as a Explicit model. P stands for permission, LI stands for limited information, SS stands for specific suggestion, and IT stands for intensive therapy. So what is this Explicit model of intervention? When patients come with sexual dysfunction and sexual issues, right? As a professional in health, we should give permission for the patient to talk about it. Typically in society, people don't talk about sexual issues and those things so easily because of the stigma, right? Because of the stigma, they're hesitant to talk about it. So as a healthcare professional, giving permission or telling the patient it's okay to talk about sexual issues makes them open up and talk to you about their sexual issues. So that's number one, P, permission. Then what is limited information? In a lot of patients with sexual issues, we know a lot of them have myths and misconceptions. They have myths and misconceptions because they are not very much aware about sexual education. And so giving limited information about what sex means, what activities mean, what's right, what's wrong, what myths, misconceptions could help them to clarify their head and actually feel much better and reduce their anxieties. That is limited information which is being passed on. And as you assess the patient, you also might know that there are specific suggestions which are required for the patient to feel better from their sexual dysfunction, and you help them with these specific suggestions, and if need be, going on to working on intensive therapy, doing intensive therapy to help these patients with sexual dysfunction. This is what is called as Explicit model. Permission, limited information, specific suggestion, and intensive therapy is what is called as Explicit model. With this, we come to an end of this INI-CET recall. There are a lot of other overlapping questions and questions from kind of integration. These will be discussed with you by the other faculties of Marrow. Thank you very much for listening and watching.